I would like to introduce you to Dr. Inderjit Mehmi, who has come and now is spent more time in his career with us than anyone else. And it is wonderful. One of the things that is important to me is coming and working with someone who has just pure energy and an interest in building program. And it's great to have a partner to build. And he'll tell you about a place where we're not really making as great of a breakthrough in some of the rarer melanomas. And so I will start this and bring Dr. Mehmi up.
Thank you, Aim. Thank you, Sam, for letting us talk about some of the most important things that we could do to improve our patients' lives and continue to improve care for melanoma, and perhaps the knowledge we generate in melanoma, lending it to other malignancies to improve quality of life, disease control issues in that space as well. So the topic that I'm given today was actually difficult, I thought, because I'm to talk about disease or sub-diseases in melanoma space that we don't know a whole lot about, and why does it happen? How can we go after it? The thought is, if you don't know why it happened, how can you cure it or control it? But I think we're taking some baby steps that are allowing us to lead into that space where we can talk about what Dr. Hamid talked about earlier in typical skin melanomas, where the response rates are great, where the durability of these responses is amazing. And then we're talking about survivorship after 5 years, 7.5 years, and 10 years. I think all those things are important, and we want to bring those into what my topic of discussion is, which is uveal melanoma, mucosal melanoma, and acral melanoma. And I'm going to try and give you a little bit of what the current state of care in these sub-disease melanoma space, and then what are some of the unmet needs. I think there's a lot more unmet need than there is standard of care to be. So my objectives of the talk today is give you a little bit of background in all these three different subspaces, what is the current state of care, and what are some of the future directions. I wanted to give you a pictorial here. The uveal melanoma, there's three different compartments where the uveal melanoma can develop, and mucosal melanoma can happen anywhere from mouth to anus. And acral melanoma is essentially in the palm or in the sole of the feet, and also in the nail bed. Okay. So we'll start with uveal melanoma. Dr. Hamid talked a little bit about some of this space. Again, it's one of the most common primary cancer of the eye in the adult population, but it represents only a small fraction of melanoma in general. About 2,000 cases per year in the US, and about 8,000 globally. So not a huge space in disease, which makes it difficult to conduct clinical trials that will generate reliable data leading to approvals. And that's why the progress in a lot of these small rare disease subtypes tends to be slow, because we just can't generate enough reliable data. Trials tend to be small, and then we always doubt these trials, like, hey, this is only 40-patient trial. How can you rely on that and put it into practice? So we also know that, in early disease where it hasn't spread to, beyond the eye, we know that we can pick some of these patients out and watch them closely, perhaps institute some therapies early when they are without any metastatic disease, to see if, we can spare them of the metastatic disease in the future. And, doing gene expression profiling, that's what GEP stands for, and the PRAME, on these uveal melanoma cells, you can classify these melanomas into good versus bad categories, and perhaps take the bad or poor risk categories and treat them early enough and save them early. Okay. So that, taking the bad actors in early disease and acting on them, giving them some sort of therapy, let it be oral drug or IV drug, see if we can prevent these recurrences. It hasn't been very successful in uveal melanoma so far. There have been a number of trials. All of them have been relatively small in numbers, and that's probably one of the reasons why that data can't be relied upon. But there are ongoing efforts in in drugs that are approved in metastatic setting, for example, Kimtrak or tebentafusp, we'll talk a little bit about that. That's being we're trying to bring that into adjuvant setting and see if we can prevent some of those recurrences, and that's the future we'll talk about. So when somebody has recurrences from uveal melanoma, there are a number of different options available if the disease is localized in the liver alone. And one of the slides that I went from, it's a predominant number of patients with uveal melanoma. When they do recur, they tend to recur in the liver, or liver with another organ, and that comprises about 90% of the patients. And so the thought is, if it's liver-only disease, why not just treat the liver itself? And that's a good thought, and it's brought reasonable amount of disease control, spared people of systemic side effects most of the time. And if they do have systemic or whole body side effects, they tend to be for a limited period of time. And for that purpose, you have a number of different options. There are different embolization procedures, chemo or immuno, radioembolizations, where you're giving the radiation beads to the tumor area, and hepatic artery infusions. And I'm going to talk a little bit more about that today, and trying to control the liver-only disease. So for that purpose, let's talk about percutaneous hepatic perfusion, or PHP, with melphalan for patients with ocular melanoma with liver metastases. And this is the FOCUS trial that actually led to approval of this procedure from a company called Delcath. And it's, like I said, it's FDA approved. And they looked at two groups of populations where they got either the melphalan infusion or standard of care, and led to improvement in progression-free survival and overall survival. And based on this data, this therapy is approved. And I think we're getting ready to the point where this therapy will be available through the Angeles Clinic. And I think it's a great step towards another tool that we have for our patients to control their disease. This is the second hepatic infusion trial that, again, shows great results and in controlling the disease, improving progression-free survival, but it's not an option that increases overall survival. And that makes sense. If the disease is going to cause death in a patient, it's probably all over rather than just liver alone. So here we're attempting our efforts to disease controls in the liver only, and we're ignoring the rest of the body. So that probably translates into that, you have good benefit in sort of delaying those recurrences and other places or in the liver with this liver-directed therapy, but you're really not focusing on the whole body. And so that's why we don't have a good overall survival benefit with this approach. So we also know back from the CML days that most of these cancers have some sort of their cellular machinery signal mistakes, right? In CML, it's the Philadelphia chromosome. In skin melanomas, it's the BRAF or the NRAS or NF1, some of those gene mutations that sort of lend this gear to the cancers that puts in a drive. And for skin melanoma, we know we have 3 different combination oral drugs that we could use to turn that gear off. And we're trying to find that in uveal melanoma as well. And I think we're there. Okay, I think we're there because the earlier data targeting PKC and MEK inhibition is probably that. And this is an IDEA study from biopharma named IDEA, IDE196, which is a divarasib combined with crizotinib. And it shows a very good disease control rate, perhaps overall survival benefit as well. And this is currently going in phase 3 study where patients who are HLA-A*02:01 negative, they'll be randomized to either this combination of divarasib with crizotinib versus standard of care therapies. And I think it's going to show that this is probably the first oral combination that's going to be available for our patients. so we also, one of the things I didn't mention is that the uveal melanoma itself is sort of an immune barren. It's not very inflamed or the hot tumor that Dr. Hamid was talking about. But there's still a subgroup of patients that can benefit from immunotherapy. So this is the trial that Dr. Patel led over at MD Anderson when she was there, and looked at nivolumab and ipilimumab in metastatic uveal melanoma and showed that about 20% of the patients actually benefit from this approach. So now we're looking at, we've got 100 patients. How many can we sort of, control with the tools that we already have in our box? And the ones who can't be controlled, what are some of their options, right? So it's always amazing when there are two different groups of people studying the same phenomena show the same results. It just shows you the strength in that concept. So not only Dr. Patel's group showed this benefit, but the same data from, or similar data from Spain showed the same thing, that there's about 18 to 20% of the patients in uveal melanoma that are metastatic. They can be controlled with ipi-nivo. But the challenge with ipi-nivo we always talk about is the toxicity. The dose that we use in uveal melanoma space is a higher dose ipi and low dose nivo, and that comes with about 50% toxicity risk of grade 3 events, and that's severe colitis or dermatitis or any kind of itis that you can think of. So, and then this is the third immunotherapy options that Dr. Hamid hinted towards, which is tebentafusp for Kimmtrak, FDA approved. Now we have 3-year outcome data that's persistent overall survival benefit. One of the things, sort of the difficulty in using tebentafusp is measuring who's responding from our traditional testing. For example, CT scans or PET scans. And so we're using ctDNA, circulating tumor DNA, the DNA that is shed by the tumor itself and into the bloodstream, and we're able to test it. And if that DNA level is decreasing, that's a good indicator that these patients are responding, even though their scans may not show that. Okay. And there's a concept of treating somebody beyond progression, meaning the scans show the disease is getting bigger. But this trial showed that actually people who were kept on Kimmtrak after their initial scan showed that their disease is getting worse, they actually had overall survival benefit. So that's a huge concept in immunotherapy. I don't think it's such a huge concept in anywhere else, but in immunotherapy, it's a huge, even for non-uveal melanoma patients, we often look at their first scan, and if the progression is not significant, if their clinical status is not deteriorating or their organ function isn't deteriorating, we tend to keep them on the same therapy they've been on. And in a number of patients, you can see on a subsequent scan that the disease is actually getting smaller. Saying that this is a concept, and these concepts come into play at center like this, at center where Dr. Sullivan's from, and with Dr. Patel's center, because that's where the expertise is. And that comes back to what Dr. Hamid's saying, have your local oncologist, just chat with the expert and give them their opinion so we can take care of these patients the best way we know how. Dr. Hamid already talked about this. This is the next sort of T-cell engager, the matchmaker, targeting a different antigen on the cancer cells, PRAME, and it also showed that uveal melanoma is probably a good space where this will have activity. The initial data shows that, yeah, that is the case. And now we're hearing about T-cell tumor infiltrating lymphocytes in skin melanomas. We're hearing about it in cervical cancer. We're hearing about it in non-small cell lung cancer, a number of other spaces. And why not in uveal melanoma, right? But it's been challenging. The response rates or disease control rates hasn't been as good in uveal melanoma, perhaps because it's not so inflamed tumor in a sense. So this was one of the initial trials, and at MD Anderson last year at ASCO, another trial was presented where at least we're seeing that we can generate these TILs from the tumor, and that gives us the ability to at least infuse them back, see if we can control the disease. Also, they're looking at additional protocols. Usual time from till harvest to treatment, what Dr. Ferry is going to talk about, is about 4 or 5 weeks. Is there any way to shorten that time period? And I think there are a number of protocols in practice to, or at least in research, to see if we can do that. This is one of the trials that we just almost completing at the first phase of it, which is combining tumor treatment fields with immunotherapy. And I think within about the next month or so, we'll have the first 10 patients accrued, and we'll analyze the data and go to the next step. This is actually one of the more exciting trials that I've seen come out recently for uveal melanoma. SD101 is a toll-like receptor agonist made from bacterial DNA. There are some fundamental differences between our DNA and bacterial DNA. And by using these oligonucleotide short pieces of DNA and injecting it into the tumor, we're able to make these tumors more inflamed. Okay, I was part of the initial trial when I was at West Virginia University, where we treated patients with melanoma and head and neck cancer in combination with Keytruda or pembrolizumab. And that work is already published in JCO. And now this company, the initial company actually didn't pursue this any further, and the rights to the SD101 were bought out by another company called Toenails. And what they're developing is for how can we infuse this SD101 into the liver metastases of a uveal melanoma patient and have the most impact. And they've developed a specialized catheter and delivery of the drug, infusing this SD101 into the liver and making the concentration of this drug high as possible. And they've shown really good results, very good disease control. And I think Dr. Patel was part of this group as well. Okay, now that we talked about uveal melanoma, I gave you some what's the center of care and where we're going in the future. Let's talk a little bit about mucosal melanoma. I know this is a busy slide, but I wanted to talk about a few things. Again, mucosal melanoma is not very common, right? And we don't know what the risk factor for mucosal melanoma is. We know a lot about skin melanoma risk factors, but we don't know a lot about the risk factors in mucosal melanoma. We know just a tad bit about the risk factors in uveal melanoma, but mucosal melanoma, like I said, the median age is about 70 years old, and there are no racial differences. For example, cutaneous melanoma is more, it happens more often in Caucasian population, but mucosal melanoma doesn't have the same predilection. And the primary mucosal melanoma can happen in the respiratory tract, your upper or lower respiratory tract, lungs, trachea, bronchioles, or gastrointestinal tract from mouth to anus, or genital urinary tract. And then also mucosal melanoma, when you look at some of the genetic signature of the disease, it's entirely different than what skin melanoma does. And also what I wanted to highlight is that the mucosal melanoma that happens in upper portion of the body is actually different than when it happens in the lower portion of the body. And perhaps that can give us clues in how to pursue these patients' treatments, and how can we tailor make their treatment options. And then that's the future. So these are the two trials that I think Dr. Hamid's already brought up, and they're going to be brought up again and again. There's some of the key trials that have happened in melanoma in general, and mucosal melanoma was a reasonable chunk of these trials, and that allows us to at least make some decisions for patients, since we don't have a lot to offer in this space. So Ipi-Nivo or Opdivo and Yervoy, Checkmate 067 had about 40 patients 79 patients with mucosal melanoma, and they have at least 5 years of follow-up. And, they're a reasonable, sizable, group of patients that we can actually help. And what we don't know from that Checkmate 067 trial is, where was this mucosal melanoma? Is this head and neck mucosal melanoma, or was it GI tract mucosal melanoma, or where was it that benefited the most? I think we're learning that perhaps the head and neck melanoma, mucosal melanoma, is probably more responsive to immunotherapy than the other parts. And Relativity 047 that led to approval of Opdualag or nivolumab and relatlimab, that also had a sizable portion of mucosal melanoma patients showing that they may benefit from a progression-free survival, but we don't know what the overall survival benefit when we're comparing one drug versus another. And the last little slide at the picture at the bottom, we were part of this retrospective series with the Australian group, and look at that. Is it, when you're looking back, there are a lot of pitfalls in that kind of study, but sometimes we can gain some insight. A patient's coming in with mucosal melanoma, they're not doing all that well. Should I pick a combination treatment for them with higher toxicity, or should I go with one drug? Right here, this retrospective, probably one of the largest retrospective series, showed that the using combination versus one drug didn't really have all that much of a difference in overall survival. So a lot of the time we'll push a combination to get a better punch at the disease. But if that punch is going to cause pain to the patient as well, maybe we should step back and say, okay, let's just use one drug, since some of the information that we have doesn't really show that we could use two drugs and get better benefit. I know I'm kind of going against what Dr. Hamid earlier said about combining all the tools, but using it in a context. Okay, and what else is happening in mucosal melanoma? So we've known this for a while, that some of the mucosal melanomas are very dependent on sort of different signal transductions that the cellular machinery, and some of that could be targeted with drugs called multi-tyrosine kinase inhibitors. And when we combine it with immunotherapy, we think we can pack a better punch, because there's a modification of tumoral microenvironment that allows these immune therapies to work better. And there are 3 different studies that kind of attempted the same thing with different PD-PDL1s in combination with these small tyrosine kinase inhibitor, or bevacizumab, which is a VEGF, vascular endothelial growth factor inhibitor, that sort of rearranges the blood supply and also some tumor microenvironment changes. Again, all of them show that there are reasonable methods to control the disease. All of them are showing pretty much the similar response rates. These are, again, small trials, and they would have to be looked at in a larger set of patients to make our case for these drugs being used in average patients. Again, TIL, tumor-infiltrated lymphocytes, if it's good in skin melanoma, is it good in other melanomas? Initial signal is that possibly. It's a small subset of patients, 12 patients, that TIL was used in a larger cohort of all melanomas, and showed overall response of 50%. And we haven't seen how long this impact's going to last. So that will be forthcoming. And I think a larger trial will be needed and is ongoing to make this option a viable one for our mucosal melanoma patient. Acral melanoma, right? So that's my last and third rare melanoma. Again, it's a very small fraction of all melanomas, and it doesn't have any relation to, even though our palms and soles at one point are exposed to sun, but we don't think it has that relationship with the sun exposure. Neither it has the relationship to having a light skin, light color of eyes or hair, as the other skin melanomas do. Family history doesn't seem to play a whole lot of part in it, or any kind of pre-existing mole on the hands or feet has it. And but non-Caucasian population seems to be at a higher risk. Okay, so this is, we always talk about melanoma in Caucasian population. I think this is where the other subset of population needs to watch out, right? And also wanted to talk about, so when we're looking at the genetic makeup of these melanomas, there's no one sort of genetic mistake that stands out in this melanoma. There is no sort of targetable, that BRAF kind of mutation that we can target. Only about 5% of all acral melanoma will have a BRAF mutation that's targetable. But the environment of acral melanoma, there's the melanoma, and then there's the supporting environment or inhibitory environment. That seems to be completely different than what skin melanoma has. The acral melanoma's microenvironment, the surrounding, it seems to be supportive of melanoma rather than inhibitor of melanoma. And in skin melanoma, it seems it's a little opposite, or the non-acral melanoma skin cancer. There hasn't been one particular trial that focused on acral melanoma to see how well we can or cannot control. Acral melanoma, just like mucosal melanoma, has been part of most of the melanoma studies and show that there are, a reasonable patients that could be controlled with regimens that are available for other skin melanomas. And as such, Relativity 047 that led to approval of Opdualag or nivolumab relatlimab did have acral melanoma, about 40 patients in each subgroup. And we don't know if the combination is better or one drug is better. Again, something that we need to study, because this is a small group of patients. Are we losing that combination signal because these patients are just too few, right? But there is benefit of immunotherapy in general for this group of patients. This is one of the larger series of acral melanoma that was published, again with the Australian group, and we were part of this as well. And again, it showed that there is, when you're looking back again, the pitfalls of a retrospective series, keeping that in mind, with the combination approach, we haven't seen a significant difference rather than using a single agent. Is it the function of a retrospective series? Is it the function of combining patients from different regions? Is it a function of single agent is just as good as combination in melanoma? We don't know. I think a lot need to be studied. And then we'd be able to answer. Again, immunotherapy is active in acral melanoma, and that's the frontline therapy we always think about. In summary, all these three melanomas, they're rare. And some of these, well, actually all three of them, we really don't know what the risk factors are. And adjuvant therapy or post-operative or post-primary disease treatment, role of adjuvant therapy is in the uveal melanoma, it's developing. In mucosal melanoma, don't really know at this moment. And there is developing story for neoadjuvant therapy, meaning trying to, when patients is diagnosed with localized mucosal melanoma, giving them treatments before they potentially go for surgery. I think there may be benefit of that, and that story is still developing. In acral melanoma, we always we borrow the data from non-acral skin melanoma, and we do use neoadjuvant, we do use adjuvant therapies, but the benefits may or may not be similar. And the systemic therapy, again, the list is growing in uveal melanoma, and in both the acral and mucosal melanoma, that story is still developing, even though we're borrowing a lot of the concepts and trial data from typical skin melanoma to manage our patients. Okay, thank you.